To today's COVID-19 vaccination Building Global Capacity Learning Series focused on private sector engagement. Next slide, please. For those who could take advantage and appreciate French and Spanish interpretation, both will be offered. And the best way to access them is through the interpretation button along the bottom right of the Zoom toolbar. There's a little globe with interpretation underneath. Just click on that and choose the language that you would prefer to hear, either French, Spanish, or English. If you only want to hear the interpretation, click the mute original audio button as well. Next slide. We really look forward to all your questions and comments on today's topic of private sector engagement. Please put them in the Q&A feature just to the left of the interpretation button. And we'll be following and monitoring that section and hope to get to as many of your questions as we can today. Any we're not able to get to live, we will try to get to in writing and share that afterwards. If you have any IT or logistic or questions about the certificate of attendance, please put those in the chat and we will try to help you out as best we can. Next slide. This session is being recorded, as all the sessions in this series have been, and your attendance is consent to be recorded. There will be recordings in all three languages of English, French, and Spanish. And we'll share a link in the chat to the website. They'll be in a couple different locations where you can access them later. Also, a certificate of attendance will be available through the University of New Mexico, where Project ECHO is based. And we'll share a link to that in the chat at the end of the session or a few minutes before the end. You'll complete a brief survey, and we really appreciate the feedback you give us. It helps us to plan for future sessions. Next slide. Just a note about data use. We take data stewardship very seriously, and your individual data will all be de-identified and kept confidential. The data that is shared with WHO is all de-identified. Next slide. Just as a reminder, this interactive learning series is building on two online learning series, the COVID-19 vaccine open WHO trainings, one focused specifically on healthcare workers, and the other, which today's session is part of, is related to national and subnational focal points. And we'll share links to those resources in the chat as well. Next slide. With that, it's my pleasure to hand the microphone over to Shalani Desai, who is our moderator for today. Shalani.
Thanks very much, Bruce, and welcome to all of our participants. We're delighted to have you with us today. Next slide, please. A few announcements before we get started on our main event for today. There's a couple of new updates on specific topics available through the WHO website. So there's vaccine-specific updates for Janssen vaccine, as well as a training video on identifying and managing anaphylaxis, as well as an AstraZeneca vaccine explainer. Our civic tool has been updated. That's the costing tool that many of the countries are using. And there's also WHO SAGE guidance related to that. There is a communication resource that has been updated, a communication flow diagram to include messaging for pregnant women. Next slide, please. For anyone that's available on May 25th, our Boost partners will be having a listening and learning series, and you can register on that link. Next slide, please. As far as today's agenda goes, we will be going through an overview of the private sector engagement for COVID-19 vaccine rollout. We will have a panel discussion. We're fortunate enough to have participants from Lebanon as well as South Africa. We'll then take a look at what's next in terms of our series. And then finally, we'll go to questions and answers from the audience. And just a reminder, please use the Q&A function and feel free to put those questions into that feature while we're going through. Next slide, please. So our goal for today is to provide an overview of the potential benefits and challenges of the private sector engagement for COVID-19 vaccination. Our learning objectives are to, number one, underline the importance of exercising effective governance over the private sector to overcome bottlenecks and to maximize the chance of a rapid, safe, and equitable COVID-19 vaccine rollout. Our second objective is to share the experiences of countries which are currently engaging their private sector for COVID-19 vaccine rollout. Our third objective is to inform the audience about the work carried out by WHO and partners and where they can access these additional resources. Next slide, please. With that, I'll hand over to David Clarke for our first part of the session. Go ahead, David.
Thank you very much, Shalini. So I'm David Clarke. I work in the Health Governance and Finance Department at WHO. And with my colleagues, Anna Kokoza and Orly Pavisa, we're working on private sector engagement. Essentially, private sector engagement is about helping countries to exercise effective governance over their whole health system, and particularly private providers. And today I'm just going to give a brief overview of our private sector engagement work and explain its relevance to the COVID vaccine rollout. Next slide, please. So our private sector work is very much focused on supporting countries to solve governance problems. It's very much based on a report that was produced at the end of 2019 by an expert group who looked at how WHO could better support member states with bringing the private sector into a range of different activities, which were focused initially on service delivery and efforts towards universal health coverage. But more latterly, we're now focused very much on how we can work with the private sector to scale up the resources that are needed to respond to the COVID-19 response. The work of the expert group is on the WHO website, and it's really focused on member states being able to perform 6 governance behaviors. They are in the blue slides in the middle of this presentation. And I won't go into a lot of detail about them today, but we're very happy to share more information about the report and the behaviors. And these are available on the WHO website, and we'll send you a link. Next slide, please. So with regard to COVID-19, we've started to do work on the COVID-19 situation as soon as the COVID-19 pandemic started. And we found as part of our work that the pandemic really has presented many governance challenges, particularly for countries who are trying to work with the private sector as part of their response to increase access to treatment for patients with COVID, to help with testing and tracing, and now with the rollout of the vaccines. But there are many challenges. Many countries historically have not necessarily worked a lot with the private sector, particularly in the vaccine area. And so there are a lot of challenges for countries in knowing what to do and how to work with the private sector. But we think, as part of our work, that the pandemic, in a sense, offers an opportunity, and it does create an opportunity for us to create a new way of working between the public and the private sector, so governments can effectively manage their entire health system. Next slide, please. So in terms of the private sector and the COVID vaccine situation, it's obviously there are struggles in many countries, particularly in low and middle income countries, to get vaccines into people's arms. And what we are doing as part of our work, in line with recommendations made by the Director General and in line with key documents about vaccination, that we're advising governments to take a whole of government and whole of society approach to COVID-19 response. So that means involving all government agencies in the response, and it also means involving the private sector, whether that be the for-profit private sector or NGO private sector. We are noticing that many LMICs are really struggling to roll out the vaccines, or in some cases, struggling with working with the private sector in a way that makes sure that they respect UHC principles of access, equity, and efficiency. So what we are trying to do as part of our work is what we can do to support governments to use the private sector productively to ensure that they have an effective response. Next slide, please. So in terms of private sector engagement, there are obviously some benefits and opportunities, but we also think there are some significant risks and challenges. In terms of the benefits and opportunities, given the scale that we'll need to roll out the vaccines across the world, we really do need to make sure that governments have access to all of the resources in their health systems. So the private sector can really be an important resource to provide capacity in relation to all sorts of immunization services, from right through the immunization supply chain. It can also improve access to health workers and vaccination services. In some cases, it can also lower costs, because in some ways, in some respects, the private sector can be more effective and deploy different expertise to deploy cost-effective solutions to the problem. It can help with secure vaccine supply chains and help with reductions of shortages to vaccine. There aren't a lot of studies about the impact of private sector management of the vaccine response, and we want to do something about that. In some cases, we are concerned that we don't want to promote low quality of immunization services due to lack of trained personnel or low quality standards. So we have to be mindful about ensuring that we maintain quality as part of work on private sector engagement. We are aware that there are gaps in regulations. And one of the issues that's coming up is those countries who are either allowing the private sector to charge wholly or in part, and like part charges for vaccines. We really do need to be careful about pricing. So we do need to do some work on how we can regulate the cost of vaccines, particularly where they're being provided by the private sector. And we do know that in many countries, the private sector are providing the vaccines directly to the public in parallel with public systems. There are also conflicts of interest that need to be managed. And because there's been, in some countries, limited private sector engagement in this space, there is a big know-how gap in relation to how to work with the private sector and how to manage these risks and challenges that we're trying to fill. Next slide, please. So what we're doing as part of our work, so Anna and Orly and I and other partners, we're working with a number of partners, including the USAID Momentum partners, who are a group of consultancies who work on vaccines in relation to projects funded by USAID. We're in the middle of developing a series of policy briefs to better support vaccine service delivery, planning and coordination, regulation and financing, communication and demand generation, how the private sector can help with all of these. And we welcome suggestions for other areas where we could provide information to member states to help them. We're also starting to collect and analyze experiences from different countries. We want to understand what's going on. We want to understand the lessons that we can learn from successful partnerships and provide information across all countries to help them with their response. And we also want to grow the knowledge base about engagement with the private sector in this area. So we can use it not just for informing work on the COVID-19 vaccine rollout, but for other immunization programs as well. And at the bottom of the slide, you'll see a link to a website where we maintain all of this information. Next slide, please. But I think what's really important is for us to hear from the countries. So we're delighted to hear colleagues to have colleagues from Lebanon and South Africa with us today on the presentation to share their thoughts and experiences with how they've worked with the private sector about their COVID-19 vaccine rollout. Over to Shalini.
Thank you so much, David. Really appreciate that, and thank you for your presentation. Let me start by first introducing our two panelists. We're fortunate enough to have Dr. Leslie Bamford with us today. She's from South Africa. She works for the South African Department of Health as the chief for the Department of Health. We additionally have Dr. Abdul Rahman Rizri, hopefully I've said that right, who's the chairman of the Lebanon National COVID-19 Consultative Committee. He's a physician by training and an infectious disease doctor. So next slide, please. For our panelists, we have 3 questions that we'd like them to address and to talk about. I'll start with Dr. Bamford. Our first question is, how has South Africa engaged their private sector for the COVID-19 vaccine rollout?
Can you speak louder, please?
Yeah, no problem. I'll start with Leslie, with Dr. Bamford first, though, if that's okay.
Okay, so we'll start with Leslie. All right.
Good morning, and good morning or good afternoon to all the participants. So in terms of how we've engaged with the private sector in South Africa, first of all, I think it's worth saying that in South Africa, we have about 85% of people do not have health insurance. So the private sector generally provides health services to about 15% of our population. And there's quite a range of mechanisms whereby the private sector is active. So first of all, in funding, most people certainly who access the formal private sector are funded, have health insurance, what in South Africa is called medical aid. They belong to medical schemes, and their healthcare is then funded through the medical schemes. There's also a wide range of providers, including private hospitals. Some of these are independent, some of these are part of hospital groups, private clinics, a wide range of private practitioners, including specialists, general practitioners, other categories of healthcare workers. And then we have a large network of private pharmacies that do not really provide health services, although having said that, they provide some limited health services, including immunizations. And these again are sometimes large retail chains and sometimes independent pharmacists. And then we also in the private sector have some occupational health services where services are provided to workers. So I think it's important to have that context because there is quite a diverse private sector in South Africa. And I think perhaps one of the challenges that we as government have had is to engage with all those different components of the private sector. So having said that, in South Africa, we have tried to implement a number of principles. So the first principle is around governance, that the national rollout is a South African process that is led by government and that involves both the public and private sectors. So I think that's a very important principle. We are committed to work with the private sector, but the vaccine rollout is very much positioned as a process that is led by government. And we have also tried to position it as part of universal coverage. So South Africa is committed to universal health coverage, to ensuring that we leverage both the public and the private sector to provide health services and improve the health of all South Africans. So again, positioned as part of universal health coverage. And then the third principle, which I guess comes from these first two principles, is that we have one single digitized information system that we call the electronic vaccine data system. And the principle is very clear that anyone who is to be vaccinated, who wants to be vaccinated, needs to be registered on that system, and their vaccine needs to be recorded on that system. So irrespective of whether they are vaccinated in the public or the private sector, the vaccine will be recorded in the EVDS. So in practice, in South Africa, we have had some delays in the vaccine rollout. We plan the rollout in 3 phases. Phase 1 targets healthcare workers, and we vaccinated just around 500,000 healthcare workers. Phase 2 of the rollout started yesterday, and now we are targeting people over 60.
Dr. Bamford, you're cutting out.
Sorry, is that better?
That is, yeah, thank you.
So as we move into the vaccine rollout, we've started with a relatively small number of sites. By the end of the week, we should have more than 120 public sector sites vaccinating, and a slightly smaller number of private sites. In terms of financing, so as I mentioned, government is leading on the vaccine rollout and has purchased the vaccines. We have a vaccine pipeline which now will provide vaccines for the entire population that is targeted, which is all adults over 18. We do have some supply constraints for the next 2 to 3 months, but we will receive large volumes in the second half of the year. So government is responsible for purchasing all the vaccines, but we will be selling on to the private sector. So where the private sector sites can indicate that they have people who are registered and ready to be vaccinated, they will be allocated vaccines which they will procure and provide to insured patients. Because the insured patients have health insurance and COVID vaccination has been declared a prescribed minimum benefit, all the medical schemes are obliged to reimburse the service providers for providing that vaccination. In the first instance, uninsured people will be allocated through the EVDS to our public sector facilities and will be vaccinated free of charge, obviously with the costs being covered by government. As we move into the surge, meaning the time when we will have large volumes of vaccines to administer, we anticipate that we will need to use some of the private sector capacity to also contribute to vaccinating our uninsured population. And we have set up a mechanism to allow for that. If an uninsured patient has been allocated to a private health sector, to a private health facility, they should be vaccinated there, and a credit note will be issued to that provider, and that credit note can then be offset against the purchase of vaccines by that service provider. So it's a little bit complicated. I may have taken a bit too long, but that really, in a nutshell, is how we are engaging with the private sector in South Africa.
Not at all, Dr. Bamford. I completely understand it. You need to understand a little bit about the context in order to be able to understand how to engage with them. And it sounds like South Africa is certainly working towards that engagement in a fulsome way. If I could ask Dr. Bierzi how Lebanon is engaging with their private sector related to COVID vaccine rollout. Go ahead.
So good afternoon, everybody, and thank you for this invitation. I assume, do you want me to answer the first part of the first question or the whole questions? Let me first of all start by saying that private-public partnership in Lebanon is not usually strange to Lebanon. We had a very strong private-public partnership in Lebanon, mainly in the public health system and mainly in vaccination. And I'm a good example of the private-public partnership. I am a university professor at the American University of Beirut, and I am heading the COVID vaccination team. So most of the people there are usually either volunteers from universities and medical societies rather than what you call public health servants. Or civil servants. We're not part of the government, yet we are advising the government and supervising the implementation. So we have been doing that for all vaccination, including definitely polio, measles, pneumococcal vaccines and other. And this is why I myself chair the EPI and the NITAG of Lebanon. So we all we have been doing that for so many years. And in Lebanon, we have a hybrid system similar to South Africa, where only 20 or 30% of people benefit from public funds. On the other hand, 70 or 80% go to private sector for hospitalization. So this is why when the COVID-19 pandemic happened, our first response really was to boost confidence and boost the assets of the public health hospitals, mainly the larger hospitals. And this is where the WHO and other international partners were really of significant help because we boosted the public hospitals and people started gaining confidence in the public assets. And this is one example is that in Lebanon, for a small country, we have around 180 major hospitals. 30 of them are only public and 150 are owned privately. So, and most of the university hospitals are privately owned by their universities. So when the COVID pandemic started and we assessed the need for vaccination, the whole vaccination plan was put in conjunction between the Ministry of Health, the international community, and the private sector, mainly the academia from the private sector. And then we recognized that in order to achieve herd immunity levels and to vaccinate larger number of people as expected, in a country such as Lebanon, where statistics are very difficult to obtain, we may need around 12 million doses of vaccines. The government initially, through either the COVAX or direct negotiation with the big pharma, managed to book 6.5 million doses. So 4 or 5 million doses were still needed. So this is how the solidarity idea came into application. We thought that instead of asking the government to pay more money, given the poor conditions in Lebanon following the 17 October uprising and the collapse of the monetary system in Lebanon, where the country has been completely bankrupted. So we thought that in order to save more public money, why don't we ask for a solidarity initiative? The solidarity initiative means that to asking the big companies and the people who are resourceful and to contribute to what you call sectorial contribution, means that to ask, for example, the banking system to immunize all their employees and their families, for example, to ask the national carriers such as the Middle East Airlines in Lebanon to ask not to immunize all their employees and the employee of the civil aviation and the international Beirut airport and so on. This is how the idea started, and we told them that since we are having what you call a priority list, and the priority list starts initially with age, profession, and others, many sectors in the country, the vaccination may reach them rather late and not early enough. So they were willing to be part of a solidarity movement where we can really get funds in order to directly communicate through the government to get vaccines from the big pharma. So the major really hurdle at that time, or the issue was really in order to convince big pharma to work directly with the private sector. This was a taboo for big pharma. So we thought that we follow the example of Philippines, where in the Philippines the business community negotiated a triangular agreement or triparty agreement with the government and the big pharma. So this is where we started this initiative. This initiative progressed later. It was everything that should be brought to the country is supposed to be brought through the Ministry of Health, but the Ministry of Health does not necessarily directly pay for the vaccines. The sectors who want to immunize all their employees and their families will pay through the central bank to the government, and the government will pay to the big pharma in order to get more vaccines. This was really gained a lot of popularity, and many people said that we can get vaccines, mainly vaccines from China and from Russia through the public sector. And this is where getting from China and the Ministry of Health gave them permission. We looked at the permission. We as consultants to the government, we gave our technical approval of the vaccines that are going to be purchased. And since then, people were given the right to import vaccines to the country, but they were not given the right to sell vaccines to people. They were given the right only to sell vaccines to large establishments. These large establishment or sectors are going to vaccinate their own people. They are going to vaccinate their own employees and their own family. And a very good example, I'll give you two quick examples. One is the Middle East Airlines, where Middle East Airlines wanted to purchase 7,000 vaccines for 7,000 people. So we told them, no, you cannot only purchase for 7,000, you have to purchase also for all the employees of the civil aviation authorities and for the Beirut International Airport. So they ended up providing money for 11,000 people, and they saw 22,000 Russian vaccines were brought this way to the country. The second biggest initiative was the universities, because we wanted all our universities to open in September. So this is why we encourage universities to purchase vaccines. And this is where, for example, through the government, and one example is where I work, the American University of Beirut managed to purchase 40,000 vaccines for 40,000 people to give their faculty, to give their staff, to give their employee, and to give their students, and all those who benefit from their healthcare system, the vaccination. So the private initiative in Lebanon now is gaining momentum, but we don't have to lose our track. It is still, most of the vaccines provided in the country are still mainly vaccines provided by the government. The government is the most important contributor to the vaccine in the country, and we have really, we are probably getting now a very good relationship between the private sector and the public sector. Thank you.
Thanks, Dr. Beersey. I'll go to question number 2, and I'll ask Dr. Bamford, what were the challenges that you faced when engaging with the private sector for the vaccine rollout, and how did you overcome those challenges?
Thank you. I'm going to flag 2 challenges that we are working very hard to overcome. I'm not sure that we have succeeded yet. So the first relates to coordination within the private sector. So I think when I was sketching the context, one of the things that I focused on was that the private sector in South Africa is quite diverse, and they don't necessarily always have the same interest. I mean, there is competition between the different service providers and between the different segments or types of facilities within the private sector. So in South Africa, the private sector has set up a coordinating mechanism, which is called Business for South Africa. And we have engaged and worked very closely with them. But sometimes it is quite labor intensive because of the fact that as I say, they do have, in some instances, quite different interests, and we end up, to some extent, needing to navigate some of those different interests between different parts of the private sector. The other challenge relates to ensuring that there is the correct balance or alignment between demand for vaccines, supply for vaccines, and capacity to deliver the vaccines. So within the public sector, we can manage that a little bit more easily. But within the private sector, capacity to deliver is not necessarily evenly spread across the country. And so there are concerns that we have overcapacity in some parts of the country within the private sector and undercapacity in other parts of the country. Now, the distribution of the private sector is relatively aligned with the distribution of the insured population, but particularly when we look to the private sector assisting us with providing, vaccinating the uninsured population, there are concerns that there's not geographic alignment between where the bulk of the uninsured population resides and the footprint of the private sector. So I think to recognize those as 2 challenges. In terms of managing them, as I say, there is a coordinating structure for the private sector, and we've really tried to encourage the private sector to coordinate itself as far as possible. In terms of capacity, we will be looking at that very closely. As I mentioned, South Africa, the vaccines have been procured by government, and government is responsible for allocating vaccines. So we do have some leverage there to ensure that there's the correct balance between demand, supply of vaccines, and capacity to deliver vaccines. So I think I'll leave it there. Thank you very much.
Thank you, Dr. Bamford. Dr. Beersey, I wonder if you could share 1 or 2 challenges that you have faced in Lebanon and how you have overcome those challenges. Could I ask that you please speak slowly, because we do have simultaneous translation. So if you could speak slowly, it'll help our interpreters. Thank you.
Thank you. In fact, the major challenge, some challenges are very similar among all countries, which is the availability of the vaccine. And many people initially thought that by going private, especially in the press, because in Lebanon everything becomes a political issue. And I'm sure that the COVID pandemic is political, is a major political issue. That so why don't you engage allow people to get more vaccines through private sector? When the government decided to give more than 32 permissions for importing vaccine, most of those people who took it, they were not able to get any vaccine. So first, so the demand is much higher than the supply, it seems, all over the world, especially that countries that produce vaccines have a problem at their national level in order to provide these vaccines. So this was a major challenge. The other challenge that really we wanted to overcome was we don't want to discriminate between people who have and people who do not have. This was really because for example, I myself on my part and many of my colleagues, we accepted to volunteer for this job given that we have 5 issues. The first issue is that everybody on Lebanese soil should receive the vaccine, irrespective whether they are Lebanese or not Lebanese. The vaccine should be for free. The quality of the vaccine should be impeccable, and the choice that the people want to be vaccinated or not is their choice. So this is why when the question really was, if you allow the private sector, it means that you may be giving a leverage for people who have money to buy the vaccine versus people who do not have. So in order to overcome this, we only insisted that the private sector can be engaged only in what you call on a sectorial basis, on a sector basis. Means that, for example, if the Chamber of Industry wanted to get vaccines. So we told them, you can get vaccines if you provide the vaccine for all your labor force, for all your administrative, and for their immediate families. And more likely, initially we insisted on that. Now we probably are loosening it up, that you have also not only to contribute to your sector, but you have to give a certain part of your contribution to the government. So the government will use that contribution also to provide quicker access to vaccine in sections where probably if there are no what you call a sponsor for that. In Lebanon, we are the country with the what you call highest refugee per capita in the world. We know that officially in Lebanon, we have more than 1.5 million refugees for a country which the whole inhabitants are 6 million. So more than 1/3 of the population, or around 1/3 of the population, can be a refugee population. So how to reach this refugee population, mainly the Syrians, who have political issues also and security issues related to them, and the Palestinians, aside from what you call the working labor force, that at least half of them are present in the country on an illegal basis, was another challenge. So this is where we went to the private sector. We told them, we went to the Palestinian community. Many of them are very well to do. So we had a joint venture with the Palestinian community and the government. We told them we're going to provide the Palestinian like Lebanese, the Syrians like Lebanese, anybody else like Lebanese. But in order to facilitate, we want your help also to help in facilitating. When the vaccines were probably available, we faced the major obstacle that many of these communities were not willing to register in the national platform. They thought that for example, in Lebanon, we have 1.5 million registered on the platform out of an expected 5 million or 5.5 million that should be registered by now. So we thought that the Syrians and the Palestinians and some part of Lebanon are not registered. So even with the private initiative, how can we make the vaccine reach them? So this is where we also ask the help of the private sector in order to help us reach this group of people, telling them we are discriminating between, or differentiating rather than discriminating between, your legitimate stay in the country and your right to the vaccine. We are not what you call, you are not a USAID agency, or we are not any immigration agency. We are simply representing the national government in order to provide vaccine for everybody on Lebanese soil, irrespective whether your status is legitimate or illegitimate. So this was really a major impediment or a major hurdle that the private sector through universities, their ability to communicate through their social welfare departments, and the non-governmental organization which represent an important section of Lebanon, whether be it a private or international local component, helped us reach this community.
Dr. Bearsy, thank you very, very much for that. That is really interesting. In the interest of time, I would like to go to question 3, and I'm going to ask Dr. Bamford first for one lesson learned that you'd like for our audience to take home, and I'll come to Dr. Bearsy next.
So I think our number one lesson that we've learned, the importance of having a single information system. The COVID vaccine rollout is in fact the first time that there's a digital or information system that has been developed by the public sector that has been used by both the public and private sector. Now, of course, it is still early days, so we can't claim success yet. But I think a lot of the success that we have achieved so far in terms of aligning the public and the private sector has been firstly because vaccines are procured by government, and secondly because we have a single information system that all sites and vaccinators must be registered on if they are going to be part of the vaccine rollout. Thank you.
Thanks, Dr. Bamford. Yeah, I can see how a common information system would be really helpful. Dr. Bearsy, if you had one lesson learned that you'd like for our audience to take home from the experience that you've had in Lebanon, what would that be?
I believe that I agree with my colleague from South Africa that a unified system. We are a country with no unified statistics because of many other reasons. So unifying the information system is very helpful to know where you are. And I believe that the other lesson we learned that in time of hardship, solidarity between the private sector, which represents the community, and the public sector, which should be also another representative of the community, is very important, because in hardship, giving the people the right to work together and to provide for people who have, to provide for the people who do not have, and help them, is very important, because overcoming a pandemic is not only a medical issue, it's a social issue, it's a cultural issue, is an everyday issue. And this is where, in order to conquer such a pandemic in a country, in Lebanon, which was already plagued with so many other crises, we need everybody to be part of this response in order to feel that this response belongs to them. And the acceptance of the private sector and the partnership between the private sector and the public sector gave the citizens and the individuals, population of Lebanon, they gave more trust in the public sector, because in a country plagued, quote unquote, with corruption, once you involve the society with your response, it makes the public sector more what you call more acceptable, more palatable to the taste of the masses, and give them more trust that some of their friends and some of their colleagues are already part of that response.
Thank you for that, Dr. Bearsy. With that, I do want to thank both of our panelists, Dr. Bamford as well as Dr. Bearsy. If we could go to the next slide, please. What's next? So next slide, please. All of our webinar materials, as well as continuing the conversation, can happen through our TechNet platform. They have a Telegram group in English as well as French. And all of our webinar materials can be found on that TechNet site. Next slide, please. There are two further seminars that I'd like to draw your attention to. The first one is on June 1st, which is on monitoring and evaluation of COVID-19 vaccine introductions. And the second one is on June 15th, adaptive leadership for COVID-19 vaccine introduction. Next slide, please. So with that, I do want to say thank you. We have a few minutes left, and I was just going to take a look at the question and answers that our audience have been putting in. And if I could call upon Dr. Bamford for the first question here, which is related to how you selected private sector organizations to be part of the vaccine introduction, like how you were able to allocate doses to a specific clinic. Dr. Bamford?
So as I indicated, we do have a partnership with the private sector. And as far as possible, we have requested that the private sector coordinate itself. And they went through a process of identifying service providers across the country. Each of those service providers then has to have gone through a process of ensuring that they are registered on our information system. That includes some quality assurance, making sure that they have the correct resources in place to safely vaccinate. And then they are allocated people to vaccinate through our EVDS. So currently we have a number of service providers. The private hospitals have been active in vaccinating their own staff and did assist with vaccinating some public sector health workers. Predominantly now, it's the pharmacies and to some extent the medical schemes who have set up sites and will be vaccinating in the private sector. Our expectation is that as we roll out the program, more and more service providers will want to participate. That becomes quite difficult. We cannot have too many service providers, but equally because of the need to have follow competitive practices, it is difficult for us to limit the number of service providers too much. So I think that's part of the ongoing challenge of, as I indicated, matching the demand and the vaccines and the capacity. So I hope that answers the question. Thank you.
It does, thank you. The second question, we have a number of questions. The next question that we have, if I could ask Dr. Bierzy to comment on the mechanism to report AEFIs, so adverse events following immunization, from private vaccination centers or clinics.
Thank you. Mind you, in Lebanon, we have somewhere around 33 plus 25, somewhere around 65 immunization centers. The vast majority are private sector because they belong to private hospital universities, but they work on the behalf of the public sector. So they have no special reporting mechanism. They have to report directly to the government. They receive the exact amounts from the government. They receive the instructions. They have the same SOP for operation of vaccine, the same collection of waste management and everything. So this is why we have what you call a pharmacovigilance department in the Ministry of Health, and the pharmacovigilance section belonging to the national COVID vaccination plan, which works with the government and is supported by the Lebanese University. So all of these events, adverse events in all vaccination centers are directly reported to this pharmacovigilance group. But you can report it either through the platform that you are registered to get the vaccine. You can report it through a hotline specially designed for that, or you can report it to the vaccination center itself that you have received the vaccine, and the data is collected from the vaccination center. So this we had made sure that whether the vaccination center is owned by a private institution or is owned by a public institution, when it starts operating, it operates under one umbrella, the single umbrella, which is the national public umbrella.
Thank you, Dr. Beersey. Dr. Bamford, if I could ask the same question of you, because it sounds like in your system, not all private providers already provide public vaccine. Dr. Bamford?
So I think our system sounds to be fairly similar to the system in Lebanon. So that any adverse events following immunization should be reported through a single system. And obviously there are two issues. There's where the person was vaccinated, and there's how the person presents with the adverse event. So they may return to the site where they were vaccinated, but they may present at a different health facility or not at all. So we have a number of channels. We are implementing what's called the Med Safety app. So that can be used to report adverse events. Can be reported by private individuals, but also by health workers. We have a call center where the public can report adverse events. Those, of course, also get entered into the Med Safety app. So that is the final common pathway. But as I say, the information can be entered by individuals, by healthcare workers working in a public or a private health facility, and through our call center agents. That information then becomes the basis for our pharmacovigilance program, which is jointly run by our Department of Health in conjunction with our regulator. Thank you.
Thank you. So just being mindful of the time, I do want to say thank you very much to all of our presenters and all of our panelists. I'm going to go ahead and close our session. I know there's a couple more questions in the Q&A, and so we will answer those and provide those in writing on TechNet. We'll get our panelists as well as David to provide those inputs. So with that, I'd like to thank everybody, and I hope we get to see everyone on June 1st. Thank you.
Thank you very much. Bye-bye.
Bye-bye.